no shortening of breath, common night with diaphoresis, and lasts for 30 minutes and completely relieved. The vital sign at the ED have no remarkable the patient history. He has hypertension and hyperlipidemia. He is using lisinopril, amlodipine, atorvastatin, and the blood pressure is controlled at 130/80 millimeter of and he has a 35-year smoking history. Other history is unremarkable. For example, diabetes mellitus, MI, or GERD. Physical examination showed that the patient appeared comfortable and was able to complete the sentences fully. No cyanosis, no edema. BMI is 33. No jugular vein distension. Radial pulse is clear and regular. S1, S2 is clear and no murmur. Other examination is normal. So I have the initial diagnosis of this case is the acute coronary syndrome. And the different diagnosis, I think, is the aortic dissection, pulmonary embolism, pericarditis, and pericardial effusion. Okay. So I ordered some diagnostic workup. The first is ECG and cardio enzyme. Just a troponin T, other thoracic echocardiography, chest X-ray, D-dimer for rule out EE, and manometry for ruling out GERD. The ECG shows that there are no a normal ECG, no ST and T segment change. Can you read it? Hello?
Yes, we can see it.
Yeah. Do you need time to read it, or we can go on?
Hello, Vian.
Yes. So before we go to the EKG, and I would like to ask you about normally, because we focus on the patient history, and because you give us about differential diagnosis like acute coronary syndrome, aortic dissection, pericarditis, and PE pulmonary embolism. But in your history, you don't really have a thorough history, because how we can, based on the symptom, how you can differentiate between an acute coronary syndrome and aortic dissection or pulmonary embolism. Like if you're thinking about an aortic dissection, what should you ask? Any symptom you need to ask a patient. So you're thinking maybe the patient have an aortic dissection.
About the aortic dissection, the patient should have a tearing pain, can be radiated to the back, and that is the symptom of the aortic dissection. And the pulmonary embolism, it has no specific symptoms such as hemoptysis, sorry, hormonal Just short and breath. That's it. And I think that the pain of this patient can be every of the this for differential diagnosis because we cannot rule out.
However, because you are not sure any idea, any opinion from the friend, but like aortic dissection, because it's very bad prognosis and it's very serious disease. Normally, you need to ask like a tearing pain you mentioned before. However, when you present the case, you need to write it down, because that's why when I am a reader, I never see this case before. I understand it about when you taking history and doing physical examination, you really focus and you really know about the differential diagnosis, because we don't want to miss aortic dissection, because every 1 hour we miss diagnosis for aortic dissection. The patient will increase the probability of the mortality increased to 2%. So aortic dissection is one of most topic of differential diagnosis. And you mentioned the patient have a tearing pain and the patient have any pain in the back. But in your physical examination, you need to tell about how is the blood pressure in the both hand. It's very, if when you measure in a left hand and in right hand, and if have a difference between the blood pressure in the left hand and right hand, it's one of the most very specific physical examination for the aortic dissection. So I'm thinking when you present the case and you really focus on it and any symptom and the blood pressure, because aortic dissection, they are related to blood pressure. So I'm thinking you need to, in history and in the patient history, you need to ask about whether the blood pressure is under control or not, whether the patient is complying with medication, what kind of medication for the blood pressure the patient using, and how compliant the patient is. It's very important. If the patient is not compliant with medication, and if the patient admitted to our hospital with a chest pain, with a severe high blood pressure, and aortic dissection is one of the most top list, #1 differential diagnosis. And for the pulmonary embolism, so I'm thinking normally the patient may have a dyspnea, may have a difficulty breathing. However, some patients, when the thrombus, they only obstruct a small vessel, because a small thrombus, maybe the patient doesn't have a difficulty breathing, but the patient have a typical chest pain. So you need to ask the patient whether the pain will, when the patient breathing and breathe out, whether the pain was getting better or getting worse. If the patient said when the patient breathing and the pain getting worse, it's the most really specific symptom of the pleural pain. And then you need to ask the patient, is there any flight, long flight the patient have? Because maybe the patient have a long flight and it's one of most, it's a risk factor for the patient. And then with the patient, with the aging, like this patient, 62 years old, and one of most common, if the patient have a PE, the most common risk factor is a cancer. So we need to screen the cancer for the patient, especially the patient with the aging. And so we will ask about how about your bowel movement, because the most common cancer in this age is the colon cancer, as you know. And we need to ask about how bowel movement, any blood, any losing weight recently, any fatigue, any tired, any night sweat. That's why we screening about the systematic symptom for the cancer. And we need to screening colon cancer, lung cancer, it's the one, and prostatic cancer is the most common cancer. And if the patient have a cancer, it's a risk factor for the pulmonary embolism too. So in the history, I'm thinking it's much better if you focus on it too.
So you mean that cancer can cause pulmonary embolism?
Because when you have a cancer, you increase the coagulation in your body. So it's the most common. They can cause the thrombus. Because if the patient have a cancer, the coagulation status is increased, so it can cause a thrombus. And then pericarditis. It's because when you look at, when I listen to your history, it's very typical for the acute coronary artery syndrome. However, we need to very cautious about if the patient have a really typical, but the EKG is normal. Of course, EKG is not really sensitive in diagnose the patient with the acute coronary artery disease. But we need, and when we met a patient, initially we need to ask about why is EKG is normal. Is there anything we miss a diagnosis? If EKG show about ST elevation, it's very clear because the patient have acute coronary artery syndrome. However, EKG show me it look really normal to me. It looked really nearly normal to me, and so we need to be cautious. Maybe we miss some diagnosis, and we need to ask more the aortic dissection and pericarditis. How about a pericarditis? Do you ask the patient about? Normally, most common cause of pericarditis is that a patient have a flu, the virus infection before. Do you ask the patient recently? The patient have any sneezing, any cold, any fever?
I just asked about a fever and some such as fetish, but I haven't think about the flu.
Because as you know, the most common cause of pericarditis is the inflammation of the pericardium. Pericardium is the virus. So we need to ask about if the patient have the flu symptom before, like sneezing, cough, tired, muscle ache. So we can screen in the patient.
Oh yeah.
And
you go.
and then the after normally when I did a rotation in Vietnam when I was a graduate, normally I will taking the physical examination. I will palpate because maybe the patient have only muscular symptom, muscular from the pain from the muscular. So you need to when a patient have a chest pain, you need to palpate the chest to see any the locus, the local pain. If you touch and if you palpate the chest pain, the patient says it's really hot at this point. Maybe you worry about maybe the patient may have a muscular problem only. So in the physical examination, it's better you write it down about it too, because that's when I read it, I know you are really know about the differential diagnosis. And is there any question?
I don't have any question at this time.
For the EKG and so anybody, I mean, do you have any question or any challenge? I mean, anything you think in your mind about anybody? I mean, so the EKG, can you read the EKG for me? I mean, can you read it in a thorough way? It's not about not only ST elevation, it's about how about sinus rhythm, how about PR, how about a QRS, how about any arrhythmia?
The ECG is the sinus rhythm with the Frequency is about 67. Normal P wave, normal PR segment, and normal P1S, no SP and T change.
How about the Q wave in a D3?
3.
Q wave in a D3. What do you think? Is it normal or is it abnormal?
This is abnormal, but the Q wave present in just one is not a it's not something we concern. I think should be present in more than one.
But do you know any reason why the Q wave? Because I agree with you, the Q wave must be in a 2 consecutive lead to diagnosis about the old myocardial infarction. But it's very interesting because you see a Q wave in a D3, and is there any reason? I mean, in your mind, do you think about any Q wave? Because you don't commonly see a Q wave in a D3.
It's because he has history of chest pain, so the most common reason I think about is past MI. Yes, this is not that specific in this case.
Can you say it again? Sorry, I miss it. Can you say it again?
The most reason I think about is the MI, the past MI.
But like you mentioned before, because the Q wave in the MI, the old MI, I mean the previous MI, they need to be in a 2 consecutive lead. Like if the patient have a Q in a D3, they need to have it in the D2 or the AVF2. It's one inferior myocardial fraction. However, the patient only have a D3, and it's a they say it's a variant common, but it's it's very interesting to read in the EKG and you see the Q wave in a D3, and the reason why the patient have a Q wave in the D3, and I think it's that's why I really like EKG. And the second thing I think is abnormal. When you look at the V1, can you look at the everybody look at the can see a V1? Do you see any abnormal in the V1? It's different from a normal. To be V1 is very suddenly different from a normal, but can you see any difference in the V1?
See any difference?
So in the V1, I'm thinking you can see the R-S ratio. Normally in the V1 in the normal people, the R-S ratio, the R wave very small or tiny. But when you look at the V1 here, you can see by the R wave is large and maybe equal to the S wave. And they have some, condition cause maybe the patient have a right, hypertrophy or right ventricular dilation. And if what I'm thinking now, if the patient have a chest pain and have a RV dilation, we need to think about the patient have a PE, pulmonary embolism. Because why the R wave is much larger compared to normal. Normally, R wave in the V1 must be very small and tiny, as you know about, it's normal. But the R wave here is large. So the first, diagnosis is the RV dilation. And now, if in this situation, RV dilation with the chest pain, and maybe we can thinking about the patient have a pulmonary embolism. The second thing, R wave here, S wave, in a patient with a typical chest pain, if the R wave is large, and you need to measure, for me, you need to measure the V7, V8, and V9 to diagnosis the patient have a posterior wall infection. I'm not sure have you ever heard about it?
Yes. And I have ECG show these.
Do you have an EKG showing V7, 8, and 9? So look like we don't have it. Normally, posterior wall infection, they often concurrent with the inferior, but, they have some, they say it's about less than 5%. They have an isolated posterior wall infection, and it only appear in the V7, V8, V7, V8, V9. And one mirror sign is the R wave in the V1 is a large. And in this situation, if the patient have a really typical chest pain, and with the R wave in the V1, I'm thinking it much better. We order the V7, 8, and 9, and it's very easy to record it too. So.
Yes.
Okay. And is there anything, any opinion, any idea from your group?
My friends, do you have any idea about the case?
So if nobody, has opinion, I'm thinking we can move forward.
Okay. And the exchange the turbulence we measure here. This is the past turbulence when he have chest pain, and this is the time at administration, and this is the time after 6 hours and 2 following days. So we can see the ECG. Yes, sorry, the troponin is normal.
It's a high sensitive troponin, or it's a normal troponin?
Sensitive.
High sensitivity. Okay. It's normal, huh? Do you remember the normal value of the high sensitivity troponin?
Less than 40.
Okay.
So other diagnostic workup, other see normal.
It looked like normal to me. So in this situation, the patient have the typical of the chest pain, like you described in the history, but the EKG normal, the troponin, is normal too. And do you calculate a TB score?
I didn't calculate TB score, but I calculated the grade score instead.
Yeah, grade score is fine too. Well, how is grade score?
Grade score is 105.
It's very low risk. It's a low risk of grade score. I'm thinking a TB score is a low risk too.
Yes, and I think it's 2.
And so in this situation, is there any, the laboratory result you want to show us? Is there anything else? How about the X-ray? Could you show the X-ray to us?
The X-ray is normal, but I can't see the X-ray. Sorry about that. but I have the echocardiogram.
Okay. It's really normal to me too. But you know, I'm thinking, you know, the X-ray is very important. If you can show me later, or you can send it to me my email, because we can go over the X-ray, because now you have a differential diagnosis, and in the X-ray you will looking for the specific sign. It's very easy to miss. It's very easy to miss if, you know, if only, you know, you're reading, you know, from the top to the bottom, and it's very easy to miss. But however, with the symptom of the patient, in our, you know, in my mind, in our thought, we know some differential diagnosis, and based on differential diagnosis, we will looking for a specific sign. I mean, specific sign in the X-ray. Same thing with, you know, the echocardiography is normal. However, you know, if, you know, we can review, you know, the EKG, you know, the echo together, I'm thinking it's much be, you know, helpful, because we want to look at if the patient have how about the RV dilation. It's very important, because we worry the patient may have the pulmonary embolism. It's one of our differential diagnosis, so we can look at about the RV dilation, how about the pulmonary, you know, hypertension too.
I don't know why, but I can see the results in the case. See, cái
Can you
bệnh
say
án.
again?
Yeah. Em không có thấy được nó trong cái bệnh án.
Okay.
You know, maybe the doctors didn't order.
Okay. How about the D-dimer? Because of pulmonary
Dimer, no results. I'm looking for it, but no result. Sorry.
Oh.
Yes, maybe the doctor doesn't think about PE.
Okay. But in reality, you know, in this situation, you know, I'm not sure. It depends on the differential diagnosis. In this situation, because the patient with the smoking is very and really heavy smoking.
Yes.
And currently the patient smoke, you know, 1 pack a day in 62, as you know. And now the current recommendation for the patient with the aging more than 55 and heavy smoking, the patient have a screening with the CT scan. I mean, the CT scan to lung tumor. And in this situation, you know, we cannot exclude or rule out the pulmonary embolism. And D-dimer is very easy test. And if the D-dimer is normal, and in this situation, we can a little bit assure us about maybe the patient don't have a pulmonary embolism. However, if the D-dimer high, and it as you know, the D-dimer is very good for a rule out, but it doesn't have give us any, you know, idea about a ruling diagnosis. But they can give us the idea if the patient have the pulmonary embolism or not.
Yes, I know. D-dimer has a high specificity, so
it's really high sensitivity, but really low specific or specificity.
You just mentioned that if it is low, if the D-dimer is low, we can rule out a PE.
Yes.
So I think it's high specificity.
No, it's a sensitivity. When you rule out, when you screening test, it's the mean about it's very easy to remember screening test or like a D-dimer in a PE, and you want to focus on the sensitivity. And so D-dimer really high sensitivity, but low specificity. Meaning about if they are normal, meaning you can rule out very 80%, you can rule out the pulmonary embolism, but it increased. It doesn't mean anything. It may be the PE, it may be from the acute myocardial infarction, because acute myocardial infarction, D-dimer still increase, mild increase. Okay. So any laboratory test or any opinion in this situation, in this case, you may think?
I'm thinking about GERD too, but in Vietnam, we use wood. No. Ở Việt Nam đó mình xài nội soi để mà coi cái quản mà không biết là ở Mỹ they use in the US.
However, when you have a diagnosis, you thinking the patient have a GI symptom, most likely you said it's a reflux regurgitation. But as you know, regurgitation, the endoscopy is not a diagnosis test, because that, as you know, regurgitation, the gold standard diagnosis is the pH monitoring. It's not endoscopy.
In Vietnam, we don't do that.
No, normally here we don't do it. They don't do it. So, but you said endoscopy, but the reason why you do endoscopy, we must have a reason why you do it. I mean, when you're thinking if the patient have a reflux, and you said about maybe we do endoscopy, but what my reason is endoscopy doesn't ruling or rule out reflux. That's why in this situation we don't if you don't think about ulcer, or you don't need to do an endoscopy. Most likely in Vietnam, or I'm thinking United States too, because of reflux, you first, if the patient have a typical symptom, you give empiric medication, you give the patient PPI. And if the patient, you treat
it right away, and then we endoscopy later if the symptoms not relieved.
Yeah, you say about when a patient, when you think in this patient, for example, final diagnosis the endoscopy, final diagnosis the regurgitation. The first question you need to ask whether if the patient have any potential complication or not. The potential complication, as you know, is the Barrett disease. Barrett, and the most risk factor Barrett disease is the time the patient, how long the patient have a regurgitation. And current recommendation is that about if the patient have more than 5 years of the reflux, you need to do the endoscopy to rule out a Barrett disease. So you need to like a risk stratification. Like me or you, we have if we have a typical symptom of reflux or regurgitation, I only give you the PPI and then wait and see to see any response. And I don't need to do any endoscopy or not. I don't need to do endoscopy. However, if I see you and you said you have a 10 years of the regurgitation and you respond to the PPI, but however, I will order you the endoscopy to make sure about I rule out a Barrett disease or adenocarcinoma. As you know, because after 10 years, the regurgitation, the patient may have a Barrett disease and adenocarcinoma of the esophagus. So in this situation, what do you do next? The patient have a typical symptom. However, they don't have any EKG abnormality in EKG. They have a normal result in a laboratory test, including the troponin. And for example, in this situation, I give it to you normal D-dimer. What should you do next? It's very common in a real life. And what you do next?
I will do MSCT.
Why you need to do MSCT? What are you looking for?
To rule out throughout the acute.
MSCD cannot give you the cannot help you ruling or rule out acute coronary artery syndrome.
So I do no vitamin ultrasound.
Now we risk stratification. For example, in this situation, you still think, like you still think about a patient have the coronary artery disease, and you calculate the TIMI score, and you calculate the grade score. Both of them is a very low risk. And what should you do next? What test should you order for this patient?
So
in this situation, if the patient have a low risk, you can order they say it's a stress test.
yes.
Of course, you need to wait, in this situation, the patient, you need to wait, at least, 24 hours, because you need to measure again, the troponin at least 3 times.
Yes,
As you know,
we already have troponin 2 times.
Yes, because of high sensitivity, you measure, 0 time at the patient in the ER and 6 hours. And then now it's how many hours difference?
2 hours later, like 2 days later.
Okay, and meaning you rule out already. So for me, my next step is to do the stress test.
Right?
It's an echo. It's an echo.
Yes, echo.
You know what? I look at the RV. I mean,
RV.
because I cannot see clearly, but because
this is the only I see.
Yes.
This is the only echocardiogram I see.
But because as you can see the PG is the pulmonary pressure is a 21. However, I'm not sure because I don't see clearly, but however, I don't think it's normally when you want to measure the velocity over the valve, you need to have a full envelope of the velocity. I don't think it's a full envelope, but I cannot mention anymore because I cannot see the image. But look like, for example, you give it, maybe it's normal. And how about stress test? Is the patient do a stress test?
Do ECG stress test.
Did the patient have it?
No. Doctor said that he do an STT right away.
So maybe I leave, the opinion from thầy Thạc Nguyễn for me, because MSCT they have a role, but in this situation, because the problem with MSCT, if you found out the patient have a 60% of stenosis, you cannot link the patient, this symptom of the patient due to the coronary artery disease. The patient, of course, if you do a MSCT, you found out about stenosis 60, meaning the patient have a coronary artery disease. However, is there any link between this symptom when the patient admitted to the hospital due to the acute coronary artery syndrome or not? We cannot, make decision on the MSCT in this situation. Thầy, do you have any opinion in this case? Thầy?
Sure. In the US, we do stress tests. If we do nuclear medicine stress tests, this is the usual way how we do here. But to do nuclear medicine in Vietnam or Asia, the cost is almost similar to the coronary angiogram in Asia. So many times they do the CT angio. Like you talk about the non-invasive CT angio. And if the CT angio is totally normal, I mean, we can rule out that the patient does not have CAD. But if the patient has some degree of stenosis, then they do the angiogram. And if they see a lesion, let's say 70%, it could be non-significant within Asia. I talk about China, Vietnam, Philippines, Malaysia, Thailand, and they do the stent for the patient. Even in the US, we will say this lesion is not significant by stress tests. And so if it's not significant, we don't do the stenting. But in Vietnam, in Asia, they will do the stenting because they presume that this is the lesion. So this is the problem of practicing medicine in Vietnam. So what Nam mentioned correctly is this is the way how they do it. But in a teaching hospital, before we do anything, we have to be sure we did all the testing correctly and we do the invasive procedure or intervention with rationale. We just cannot see the lesion and do a stenting. You see, so, but this is the practice in Asia. I cannot complain. You see, so it's difficult because the cost of the stresses in Asia, especially nuclear medicine, is maybe more expensive than the coronary angiogram. Is it correct? Can I ask in Vietnamese, Nam?
I think that the MSCT is more expensive than the CT. Sorry.
How much is that? How much does it cost an MSCT?
About 8 million Vietnam dong.
8 million, right? 8 million, right? Okay, so how about the coronary angiogram? How much does it cost?
It's much more cost.
How much?
I don't know the exactly price, but I think it's about 15 to.
Okay. Okay. How about a nuclear medicine stress test? How much does it cost? A nuclear medicine stress test. How much does it cost in Vietnam?
Oh, I don't know, but we don't do that in Vietnam. Yes, I asked the professor about that, but he said that we don't do it in Vietnam.
You know that the nuclear medicine stress test in the US, the nuclear isotope is managed under the Nuclear Commission. It is nuclear material. And in Korea, when they transport the nuclear isotope to the hospital, they had to be escorted by military people. It is real nuclear material. So this is why it's not simple to use in Asia. So let Dr. Vien and Dr. Nam, we have to wrap up because we have only 10 more minutes.
Okay. Yes. So one more thing, Thầy, in Vietnam, stress test nuclear, what in my knowledge, it's not common in Vietnam, but we do a lot of the dobutamine stress test.
You do the dobutamine stress echo.
Yes, just echo.
Yes. So at that time, we just induce the vitamin and we do the echo before and after. Nothing nuclear material in here. You
Yes,
see?
in Vietnam we don't have a
Vietnam.
nuclear. Yeah.
So you have to wrap up because Nam, he didn't mention about the management of the case yet. Is that right? We just discussed about the diagnosis.
So the MSCT results, the LAD stenosis is 60 to 80%. So I think it is a unstable angina. And management, I think the patient is just being given medication and not doing any intervention now.
It's the end. I mean,
Yes.
okay. So because the MSCT, like Thầy mentioned about already, so in this situation, normally I still do vitamin, stress test, a stress echo to find out if the patient have a functional ischemia or not. And then because if the patient have a MSCT, like Thầy mentioned now, they show about the LAD 80 stenosis. And if we don't do anything, and I don't think it's appropriate. So normally in Vietnam, when they do the MSCT, it's more than a 70 stenosis. They will do, the coronary invasive coronary angiogram. This patient. So because the patient, we don't have the test yet, we don't know whether if the patient has the stenosis or not. The important thing, because MSCT, it depending on the center in Vietnam. As you know, it depends reading the MSCT, it depends on the experienced operators too. So we don't know exactly about if the patient have stenosis or not. However, let assume it the patient have a stenosis and the patient have functional ischemia, a significant stenosis, and we diagnose the patient with an unstable angina. However, in diagnosis, can you go to the slide with the final diagnosis? So normally, if I diagnose this, I will diagnose it like normally it's an unstable angina. TMI score, grade score in it, because it's very important for me, it's very important to know TMI score and the grade score, so I can understand it's a low risk.
Why do you think it's stable angina?
No, unstable angina.
Yes.
With the TMI score with the low risk or the moderate risk, high risk, because for me it's important. And like hypertension, hyperlipidemia, it's okay to diagnose, but however, when you start, give a diagnosis, you need to know exactly hypertension. You need to know the patient have the under control or not, and how many medication the patient uses to control the blood pressure. It's very important. If the patient doesn't, comply with medication, we know exactly about maybe the patient have a uncontrolled hypertension, and it's really a strong risk factor for the coronary artery disease. And same thing with the hyperlipidemia. Here you are lacking one very important, is smoking. Heavy smoking, you need to put in a smoking as well, because smoking is very strong risk factor of the coronary artery disease.
Yes, but he already have a coronary artery disease, so I don't think smoking should be in the diagnosis.
However, smoking, like you said, like when you take care of a patient, it's not only one disease. It's that you treat the patient as the whole person, whole body, meaning you need to work. when you put a smoking, when you treat the patient with unstable angina for long term, you need to screening the lung cancer for the patient, and you need to pause the patient with the smoking, cessation, stop smoking.
That scanning lung cancer is the one who we do is common in the US, because in Vietnam I don't think that the doctor usually scan for lung cancer.
No, they do it now in a Đại học Y Dược and in some big city they start screening now.
Yes.
Because I have a friend in Đại học Y Dược and they do it a lot now. If the patient more than 55 heavy smoking, like a definition, and the patient needs to screening for the CT scan with a low dose of the contrast. And now in Đại học Y Dược and a big center like Chợ Gãy, Đại học Y Dược, they do very good about it with a low dose and low radiation.
Yes, but in some big hospital they don't do that
because they don't have a CT scan. Huh?
I don't know why.
Okay. And how about the management? Is there anything?
I think exercise, reduce SARS, and with smoking, medications. I think it's maintain the medication of the patients as atorvastatin, lisinopril, and bisoprolol. I add some more nitrate and aspirin and clopidogrel too. And the patients, we are discussing with the patient about angiogram now.
Okay.
You think there any missing drug medication or something?
So if you stick with the stable diagnosis, if we thinking it's the final one, as you know, it's a dual, antiplatelet therapy. It's an aspirin and clopidogrel, and the patient have the starting is you need to use a high dose starting. In this patient, they use the atorvastatin. I'm thinking it's good, and the patient have the high blood pressure. I'm thinking the patient use ACE inhibitor and beta blocker. I'm thinking it's good too.
Hello, good morning, good afternoon.
Hello, Dr. Pittsburgh.
Did you start already?
We are at the end, first case now.
Oh, because my time was to start at 7 o'clock. So can we start the case over?
No, Peter. Good evening, Peter.
Yeah.
The session of Mr. Nam is the first session with Dr. Viễn from Ohio. You are on time at 7 p.m. In California now. Okay.
Right.
That we are wrapping up. Then we have a new student to present the case for you.
I will be quiet.
Okay. Hello, Nam. You have 1 minute to wrap up. You want to say anything?
This is the end of my presentation. Is there anything Dr. Viễn want to say?
Dr. Viễn, do you have anything to wrap up?
No, I'm thinking it's very interesting case presentation, and thank you for sharing with me today.
Thank you.
Thank you, Dr. Viễn, and wish you well. Thanks, Nam, for the very nice, interesting, and challenging case. Now we have to give the floor to Peter, our young friend from USC.
Young friend, you're talking about my grandson. Good evening, everyone. Good morning to you. Good morning, students from Tan Tao, my friends. How is everyone?
Very good.
Good. Okay, Nam, you're who's up?
So we have another student will present the case for you.
Okay.
Okay, and he joins now. Okay, let's waiting for him.
So look, you have two cases.
No, I'm just a monitor.
The what?
I'm just a monitor, and
Oh,
There are two cases. The
Two
first
cases,
case
okay.
already presented already, and the second case is for you. And Lauk, he is a monitor.
yeah. So I only have one case this evening, Doc?
From you have from 7 p.m. to 8 p.m. your time.
With one case.
We have enough time to discuss in detail.
Yeah, that's fine.
Yes, the speaker, Ian.
Hello, good morning. Hello, I'm so
Okay.
yes, I'm done. Okay, ready.
okay, let's just screen.
Okay. Okay. Wait. Okay. So okay. Hello, I'm Phúc, and now I'm going to present about another case. For the previous one, I have presented about a DKA in type 2. Now this is another case presentation. She is an 18-year-old female patient from Bình Dương province. Her admission date is on March 18, 2021. So her chief complaint is rapid breathing. So she had a traffic accident about 4-5 days before admission, and she was admitted into the hospital for traumatology and orthopedics with diagnosis of a broken femur, and then she has a femur surgery for 2 days later. After that, she had polyuria, polydipsia, and also crop sweetness. A day later, the symptom getting worse, and she was transferred to Municipal Hospital with diagnosis of DKA and new onset of diabetes and right femur surgery. So this is about her vital signs here. So she has a high pulse, a high respiratory rate, but she's awake. Her classical signs are normal. So about her, she has her mother has a type 1, and she was diagnosed when she was 25. So about system overview, she has polyuria and polydipsia, and also crop witness. So about physical examination, she's fully awake and responsive, and she has she's very thin patient with BMI is lower than 18 kilograms per meter square. So about on when I checked her that day, all her symptoms are normal. So this is a summary about this patient. She is an 18-year-old patient with chief complaint, rapid breathing with right femur surgery. So now she has rapid breathing, polyuria, and polydipsia. And she has a type 1 diabetes mother. So when this is my diagnosis, about a 7-day post-femur surgery with DKA and new onset type 1, sorry about that, with right femur surgery propelling. And I have a differential diagnosis about this is 7-day post-femur surgery with DKA, new onset, and type 2 diabetes with right femur surgery propelling. And I have another one is hypothyroidism with type 1. And I also think about septic shock because she has a surgery about 2 days before transfer to my hospital. So I have a differential diagnosis with septic shock. So this is a lab result. At the first day she's arrived, she has high white blood cells and neutrophils is higher than the others. So she has a sepsis here. Also, she has really low and our red blood cells, also hemoglobins are HCT. So I think that she has anemia. Sorry, 2 days later. Sorry about the date. Her white blood cells normal, but she also has abnormal red blood cells. So I think that she has chronic anemia.
Yeah, can we
Anemia.
stop? Can we
Yes.
stop a moment?
Yes.
Can you tell me, I don't know if you did or not,
Yeah.
about her menstrual periods? Are her menstrual periods heavy or are they normal? Because here we're dealing with a young woman. This is pretty significant anemia.
Yeah.
And you would expect with someone who's DKA, who in the beginning is volume depleted through dehydrated, that the hemoglobin, the hematocrit would be even higher, wouldn't you? So something else is going on here. So do you have a menstrual history from her?
Mental history.
Yeah.
She's normal, so she doesn't have any mental history before. She was
And
an 12th grade student, normal 12th grade student. She doesn't have any mental history before.
so no excess bleeding that you know of.
Yeah, no, there are nothing abnormal about her mental history. I have asked her before, did she have any problems with her mental before, but she said no. Sorry.
Okay. Okay. Tip.
Okay. Okay. So this is she has iron test because she has a really low anemia. So she has about 3.7 iron test. Ferritin. So I think that she has anemia, iron deficiency.
The what?
Lack of iron in anemia. Sorry, I forgot the name.
Okay.
The iron is really low, but the ferritin is normal. So I think that she's lack iron in her blood.
Okay. We have to discuss that as well. Yeah.
So this is about her. Another one. I think that she had ketones in her blood, and also I have think about her hypothyroidism, but here I don't see any problems about her thyroid, so I think it's normal. She doesn't have any
Correct.
hypothyroidism problems. Okay, so this is about some blood glucose level. It is fluctuated from 130 to 300 to 400 every single day. I think that it depends on her meal. So I think that she's a type 1 because I don't see any patients with the type 2 diabetes in hospitals have the abnormal blood glucose level like that. I don't know.
So could you go back? What was her bicarb? I don't remember.
Bicarb here.
Oh, I didn't see this before. Okay.
No. I just
All right.
this one. So this is EKG. She just have a high pulse and I don't see any problems with her EKG now, except a high pulse rate. about over 100 high pulse
Yeah,
rate.
just a little bit over 100, correct.
Yeah.
Or about no, actually on this one, a little slower, but go ahead.
Yeah. So this is about IBG. She has an anterior blood gas. She has a bicap about 9.6 when she's transferred to my hospital. And a day later, she's also with a pH about 7.262. And a day later, her pH is increased, and also her bicap is increased to 14.1. And then I forgot to take the latest one, but about 3 days later, it will remain to the normal range.
Could you go back to the original hemoglobin?
Where the first one?
Yeah.
Yeah.
So here she's quite anemic,
Yeah.
but now she's not. So how do we explain that?
No, about I don't have the latest one, but
here you have a hematocrit. What was the first one?
this is the first one.
This is the
Yes.
first one?
Yeah.
Hematocrit is 28. Then the next day was what? I forgot.
23. The
20.
four. Yeah, one day later. 1 day later. Sorry,
23, and now it must be 38, 39.
I don't know. I don't have the latest one, so sorry about
But
that.
keep going on the hemo. You'll
And I'm sorry about that.
no.
IBJ
that's
is
all
normal.
right.
Sorry. So, okay.
Hemoglobin is 13. So
Yeah.
if you have a hemoglobin of 13,
Yeah.
if your hemoglobin is 13, your hematocrit's going to be 39, more or less, right?
Yeah.
So depending on the red cell volume, you know, if you have a microcytic anemia, it'll be different than if it's a macrocytic anemia.
Yeah.
So normally the hematocrit will be about 3 times what the hemoglobin is on average.
Yeah.
So I don't know why, if you look back when she was admitted, her hemoglobin, if you just kind of extrapolate, might have been around 9. So I don't know how to transpose the units from, could you go back to the original hemoglobin, please?
Okay.
Tuck, can you help me with the 93 grams per liter? That's basically, your hemoglobin is 9.3, isn't it? Yeah.
Yes,
wouldn't that
because
be-
it will count as, if we write it in the US, we write as 9.3 grams %.
Yes. So
This is how
milligram.
we
So
write in the
this,
US.
right. It's okay. So her hemoglobin is actually 9.3, the way we do it here. And then you have a hemoglobin 3 days later of 13 when you check the ABG.
Oh.
I have an idea that maybe you will think I'm crazy. But I've seen this actually recently. It depends how, if they took the blood doing these counts, if she had an IV going and they took the blood from the same arm, the blood's going to be more dilute as they're running fluids in. Does that make any sense? Let me give you an
Yes.
example. Tuck,
Yes.
a cardiology question, cardiology case. A month and a half ago, Gutoi said, something's wrong, I feel weak. And I examined Buz's pulse, and she was tacking and irregular, 110 to 130. I tapped it out, and it didn't seem like AFib. I thought maybe she's having multiple PACs. and she was a little uncomfortable. I said, well, maybe we should go in. So I took her in to our hospital. By the time we got there, she was much better. And so they came in, they hooked her up to this and that and everything, and they drew blood. And then they came back and said her hemoglobin was 8.1. Very, very low. So a hematocrit would be around 24%. And then the young doctor who came in and said, well, you know, she may need a bone marrow. I said, wait a minute. I think, in fact, I saw when the tech came in, my butt already had an IV running in her forearm because they couldn't get an IV in the antecubital vein. And they drew the blood out of the antecubital vein. I said, you're running D5W, dextrose in water, or maybe it was normal saline. I don't remember. I think it was normal. They gave her a bolus, right? So I said, check it again. Sure enough, her hemoglobin's 14. So I don't know if you've ever seen this happen, Tuck, but they took it out of the same side that the IV was already running. This patient that we're discussing here, if you come in with ketoacidosis, it doesn't have to be DKA. It could be any profound hyperglycemia that's been going on, and patients have polyuria, polydipsia, they're dehydrated. Your hematocrit is going to be higher, not lower. So this patient, if we believe the hemoglobin of 13, when she had her blood gases drawn, on 2 successive days, the hemoglobin was 13, both times. Makes me wonder, you know, I think maybe I'm off base, but just something to think about.
Yeah. Sorry, if I have checked it again. So I think that when the hemoglobin is ABG, maybe they forgot to check it in the to write in here. I just write into the anomals in the pH or HCl2 bicap or anything else. They don't write into the hemoglobin. So I think that's the abnormal one. I forget it because I have checked it again. So on people that
so that was a hemoglobin that they wrote in without actually doing it?
I don't know. I don't remember.
Okay.
Sorry that. I don't remember.
Okay.
I don't know that. So I think that's because I have checked it again. So I have asked the doctors who is mentored me at that time, and he said that she has anemia. So
Okay,
I say that,
fair enough. Fair enough.
Yeah, sorry about that.
No, that's all right. That's all right. We have to bring up all the differential, and you
Yes.
brought up with tachycardia,
Yeah.
possibility of could she have hyperthyroidism?
Yeah.
Well, she had a major trauma a few days before, and Graves' disease, hyperthyroidism, sometimes comes on after a major trauma, either a physical trauma or an emotional trauma. So we are seeing, by the way, more Graves' disease here in Los Angeles this year than we saw the last couple of years. My own theory is that this potent stress from COVID that people are feeling and this potent political stress that people are feeling has led to an increase in Graves' disease. Now, that's anecdotal. So what we are going to be doing is a study, getting a database of seeing how many prescriptions are being written for methimazole compared to a year before. If we get this data, we can get it from, anyway, one of the fellows working on this. Anyhow, coming back to this case.
Yes.
So you think she has DKA?
Yes.
But the blood sugar is only 380.
Yeah.
Does that make sense?
Yes. Yes,
Okay.
because in the DKA, the blood sugar is over 300, 250. So it means that she has DKA with the abnormals in APG, and she has the ketones in her blood, so she has DKA.
Yeah, so you don't need a sky high blood sugar
Yeah.
to have DKA.
Yes.
Yeah. In fact, last week, 2 weeks ago, a case was presented with DKA
Yeah.
in which the question was, well, what about the use of SGLT2 inhibitors
Yeah.
in patients with diabetes? And patients, you recall that?
Yes.
In patients with SGLT2 inhibitors could get DKA and have a blood sugar 150.
Oh.
So, yeah. So the SGLT2 inhibitors in type 1, by the way, are used at times. When we had the discussion 2 weeks ago about the use of SGLT2 inhibitors along with type 1 diabetes, I mentioned, I don't think so. And one of the main reasons is patients taking those agents, the SGLT2 inhibitors, need to be monitored very, very carefully, including measuring at home with their own ketones. Because you can have DKA with a normal blood sugar. With the SGLT2 inhibitors, what's happening is you're getting more glucose in the urine, right? You're getting glycosuria, which is one of the effects that you want, and that helps to normalize the blood sugar.
Yes.
But you also can have more ketosis. So anyway, coming back to this patient. Yeah, you can have a blood sugar of 300 and be in DKA.
Yeah.
It is unusual.
Yeah.
It's unusual to have a blood sugar of 1,000. Mostly they're in this range, 350 to 800. That's the typical range in patients with DKA. Right.
Yeah.
The question go ahead.
So I have a question about this one, because so when I check the glucose level, so I see it is fluctuate too much between 130 to about 400. So what's wrong with them? What's wrong with her? Because in the same day, about 3 hours later, it fluctuates, it down, it drop, then it's increase very high, very fast. So what's wrong with her?
How do you know what's wrong with her? I'm joking now. Can it be wrong with the doctor? No, just kidding.
Yes.
Okay, no, it isn't. So here's the situation. There's nothing wrong here. And with type 1, what is the defect? It's not secreting insulin, right?
Yes.
She's not making insulin. That's different than type 2, where the defect is insulin resistance primarily, right?
Yes.
So if she's lacking insulin, the only insulin she gets is what you give her. Even though she's lacking insulin, she still has glucagon, doesn't she?
Yes.
And glucagon actually is what's causing the ketosis in this patient.
Okay.
But so you're missing insulin, you're having glucagon. This is a very artificial situation. And this is, I mean, there's nothing wrong with her. She looks like she's doing pretty well. I have a couple of questions, however.
Yes.
If we look at the 2 days later, let's look at the blood gases.
Okay. Blood gas or
the PCO2, yeah, or the PCO2. You know, so she's still a little bit acidotic. She really shouldn't be by now. She has a bicarb of 14.
Yeah.
Go the day before.
Okay.
The bicarb of 9. Oh, that's the admission, right?
Yes.
No.
Admission date.
Yeah. Okay. You know, it really should have been corrected pretty quickly. So she should have a normal pH within, you know, at least within 36 hours, this young woman.
Yeah.
But that's right. She's doing okay. And her original acidosis, frankly, was pretty mild, wasn't it?
Yes, it's mild.
Yeah,
Mild
because you caught
acidosis.
this pretty quickly.
Yeah.
So your question is, does she actually have type 1 or does she have type 2? That's your question? Or you think she has type 1?
I think she has type 1 because, well, when I read it again, the report, I see that when her glucose level is fluctuate in a day, and I don't see it to fluctuate into type 2 ketoacidosis patients. So I think she's type 1, and she also has a family history of type 1 diabetes. So so the two ideas means that I think she has a type 1.
Yeah, I think she does. The family history is less important here. Family history is more important with type 2. But yeah, if you have you have a family history of autoimmunity, don't you? And type 1 is autoimmune.
Yeah.
She has anti-insulin antibodies, and mother has the same.
Yeah.
It's very interesting if you have identical twins.
Yeah.
Identical twins, and they have the same genes.
Yeah.
One kid develops type 1, but the concordance is only, for the other twin, is only 30 to 50%. The other one may not get it. So it's variably expressed. But yeah, mom has it, she has it most
Okay. So
likely.
yeah.
Go
So
ahead.
I have a question for you. So does she need a C-peptide test to diagnosis of a
Well,
type 1?
that'll help. I mean, yeah, that'll help, won't it? But it's conceivable she still has C-peptide. This, you know, if the C-peptide is absent,
Yeah.
then it's secure. I'm pretty sure her C-peptide is going to be low.
Okay.
You can check GAD antibodies if you have that ability. Can you check GAD antibodies?
No, I
Yeah.
don't see it.
Yeah, so that's all right. You know, here we would check GAD antibodies. We would check, you know, but yeah, C-peptide will help. But you know, patients with new onset type 1 like this still have some little bit of insulin reserve. And if you treat, and you are treating her now,
Yes.
she may get some resolution in her pancreas and get what's called a honeymoon period. Have you heard of that?
I have read just a note about that. So what is the
Yeah.
honeymoon phase after this one?
So the honeymoon period is now you treat the diabetes, you get the blood sugars down. Now the patient's pancreas is not stressed, and now they're able to secrete a little bit of insulin again, because the autoimmune process is a gradual one. So for sure, this patient, you know, I mean, she may have a honeymoon period where there's some residual insulin secretion for a period of time, but this is a gradual process. Yeah, check a C-peptide. It's
Yes.
going to be low relative to what her serum insulin is, but you can't measure that because she's already getting insulin. So, yeah.
Okay. So I will see it later if I have time. Come back to check it about. So does she have the C-peptide test or not? I will check later.
Well, you know, it'll confirm.
Yeah.
But you know, clinically, she's a thin woman.
Yeah.
With a BMI of 18 or less.
Yes.
And she has findings, biochemical findings of type 1 diabetes.
Yeah.
And her blood sugars are all over, characteristic of type 1.
Yeah.
So for your own education, check a C-peptide. Yeah. You can't check GAD antibodies, so that's okay. Here we might, if we were in doubt, check GAD antibodies. So, but here, I mean, it's a pretty mild DKA, isn't it? And
Yes.
okay, let me ask you a question.
Yes.
Let's go back to the original labs.
What? I already know what.
Yeah, there we are. You just, okay. What about the white count?
The white count.
Why does she have a high white count?
She has a high. So there are two things that she has a high white count. The first of all, she has a sepsis because she infections because she has a surgery 2 days before. So
She had what 2 days before?
A surgery, trauma surgery,
Yeah.
a femur trauma surgery 2 days before. So it may increase her white counts. And another one may be cause her white counts. It's about she has a polyuria, but I don't think that she has white counts by polyuria.
You know,
The most thing I think that she had it because she had a trauma accident 4 or 5 days before.
even right, that's a possibility. Even without the fracture, even without the trauma, her white count would still be elevated. The typical white count in a patient with DKA is what you're looking at, 15,000, 18,000, 20,000. That's the typical white count. These patients have a stress response. They're dehydrated. They have increased secretion of cortisol, and cortisol causes an increase in white count. Now, obviously, you have to be aware of an infection.
Yeah.
She had a normal temperature, but that does not mean she does not have an infection. If you're septic, you can have a normal temperature, right?
Yes.
So, but she looked too good. She didn't appear sick, did she? And her trauma was 2 days before.
Yeah, about 2 days before.
It's a little too early for sepsis.
Yeah.
So yeah, this is a typical white count. Now, when patients come in with ketoacidosis, you wonder, even though they have a normal temperature, they have a high white count, you still culture them. You make sure their urine doesn't have bacteria. You make sure that they don't have, make sure that their blood cultures are negative. You make sure that they don't have a pneumonia, right, with a chest x-ray. But anyway, I think hers is just on the basis of ketoacidosis. So my method actually is when I see a patient like this, unless I have something that suggests an infection, I do not give antibiotics.
Oh.
I wait. If I do not see findings of an infection. Now, she had a major trauma, and if she had that fracture out there, it could be dirty, couldn't it?
Yes.
Yeah. She was in an accident, and you can have get a dirty fracture. Well, I don't remember, was it closed or open? Anyway, so I don't give antibiotics. If I saw an 18-year-old, new onset DKA, urine is clear, no evidence of an infection, a white count 15 to 20,000. I treat her with fluids, insulin, the white count comes down. I don't treat with antibiotics. Nothing wrong with that. You can always start the antibiotics, and when the culture comes back negative, then you stop them, right?
Yeah.
You don't have to treat forever. So some people would treat right away with antibiotics. That's okay. It is a personal preference.
Okay.
And you know what? as you get more experience, you'll decide what works for you.
Okay.
Yeah. Yeah. So go ahead.
Okay. So about APG. So about the electrolyte from emission date, days later, she has a low potassium level, but
Yeah.
normal
Now
range.
this is that, you know what?
Yeah.
That should not happen. That should not happen. She should not develop hypokalemia.
Yeah.
If you have, what, you know, I forgot her normal potassium when she came in.
Normal range about. So the first thing I don't. Wow.
The first on the 11th
No. Wait.
or
Potassium.
13.
The 13 one. Let me check it again. So sorry. Wait a minute.
Yeah.
1 minute, 2 minutes. I check it.
That's it. What is the first day? Was the 11th or 13th?
The 13th, March 13th.
And what was the potassium?
Let me check. Sorry. I fuck. Wait. I don't see any. Wait.
I think you had it. I forgot.
I don't know that I don't see any potassium one. Maybe they forgot. So I don't know why.
So
Could
let me
the-
ask you
the-
this.
the first one.
go back to the slide? Yep, this one, the 13, electrolyte 13 of March.
No,
Yeah,
I don't
that's
see
what I'm looking at.
any. I don't see any. Sorry about that. I don't receive
Okay,
any.
the next one, go slow, don't go fast.
What?
Okay, so the first one we have it is March 14.
Yes, March 14. The early March 14 test, about 6 a.m.
Yeah. So in treating DKA, she's been having polyuria, right?
Yeah,
She's losing glucose.
yeah,
She's losing sodium.
yeah.
She's losing potassium. The average
Yes.
body potassium loss in the average patient who comes in with DKA is about 200 milliequivalents. So if she came in, let's say on the 11th with potassium of 4, which is normal, she's already low.
Yeah.
So now you give her IV fluids and she's going to urinate more potassium as you increase her kidney flow. Then you give insulin, and the insulin goes into the cell along with the potassium. Potassium, as you know, is the main intracellular cation. Sodium, obviously, the largest extracellular cation. So if you have a low potassium in circulation, you can be sure that her total body potassium is low. So as soon as you start giving IV fluid and insulin, you need to give potassium, because if the potassium goes even lower than this, then the doctor will end up calling Dr. Tuck Win to come in for a consultation because of the profound hypokalemia.
Yeah.
And if it goes below 2, then they're going to call in the pulmonary doctor because the patient may go into respiratory problems because the intercostal muscles are so weak.
Yeah.
So everybody gets involved. So let me ask you a question. Was she given, you gave her insulin and potassium and fluids?
Yes. So she had insulin, potassium, and sodium. So a day later, it's also decreased. But 2 days
Yeah.
later, when she had enough potassium and also sodium, so it increased to about 2.3.
Yeah. Give potassium. If the
Yeah.
kidney function is normal,
Yes, her kidney function is
then
normal.
it's so you're not going to cause any problem giving potassium.
I don't know why. I don't know why she has a really low potassium levels on the first 2 days.
Because she has urinated out with her polyuria polydipsia.
I have checked in the report. So all the doctors have used potassium when she's admitted, but she's only really low due to the 3 days later after she admission.
By now she's eating and drinking, right?
Yes, she can eat
So
and drink.
she should be okay. So
Yes.
she should be ready to go.
Yeah.
So yeah, she can correct this. Let me ask you a question though to begin with. Look,
Yeah.
she came in and she said she likes sweets, right?
Yeah. Yeah.
And sweets are bad for you in this.
Yes.
But why does she like sweets? I'll tell you why.
Okay.
Because her cells are starved. She's starving of glucose. She needs glucose. And her body sees, I need glucose. I need glucose. Let me give you a case I had years ago.
Okay.
The case I saw was a doctor, ear, nose, throat doctor, young guy.
Yeah.
He went to a reunion of his college or medical school class. And in the reunion, at the social function, at the dinner, there was a bar where they're serving drinks. So he went up, he was thirsty, and he kept asking for orange juice, orange juice, orange juice, orange juice.
Yeah.
And the more orange juice this guy was drinking, the worse it got. He just had to have orange juice. He wanted, and you know, when you treat hypoglycemia, low blood sugar, we give orange juice. So he had to have orange juice, and finally they had to kick him out because he was just becoming so angry. He wanted more juice, orange juice. You have apple juice, anything. And the thing is that your cells in your brain see that you don't have enough sugar because the sugar is in your plasma. It's not in the cells where it belongs. You know, it takes the insulin to put it in the cells. Anyhow, so my own thinking, I think about this by saying, okay, and I see this, patients who have uncontrolled diabetes sometimes say, you know, I want to eat chocolate, I want to eat sweets because their cells are not getting enough. Does that make sense?
Yes.
So did you give her candy? I hope not.
Oh, I can't. I can't.
You gave her insulin instead of candy. Good
Yes.
job. Good job. Yeah. So is she, tell me what her situation when you sent her home from the hospital, what was that like? You sent her home with insulin?
Yeah, I will send her home. I will send her home with I think I will use the basal bolus one. I have read it. There's two ways to use insulin in this patient. The first one is to use insulin with meals with the carbohydrate.
Yeah.
But it's quite hard for doctors and also the patients because she have to separate her meals into 6 with the 3 main ones and the 3 snacks. it's quite hard for her because she's a last year 12th grade senior year of high school, so she's quite busy. So I think I will use a basal bolus for her, insulin for her.
And with long acting at bedtime, or how are you doing that?
I will use a long acting and a rapid one in 3 meals per day, before 3 meals.
Yeah, yeah, and I think, but yeah, here we have all kinds of pumps and tandem pump and implants and all kinds of things that I don't know if you have that. You have insulin pumps,
Pen?
pumps where they're hooked to the patient like a machine.
In the machine.
Yeah, so
Yeah.
we have patients who wear a pump. It looks like a pager, looks like a phone,
Oh,
and their blood sugars are checked on their phone. They wear a thing on their arm. Every 10 days or 2 weeks, they change it, and the blood sugar is monitored continuously onto the
yeah.
phone.
Oh, so I don't
mean,
see
yeah, that's-
here quite
No, no,
Okay.
no. That's all right.
I can explain it in Vietnamese.
Yeah, yeah.
Cái cách chữa bằng chữa diabetes đó thì người ta
Yeah.
dùng một cái máy nhỏ nhỏ, nó giống như là một cái cell phone á.
Yeah.
Xong rồi cái máy đó thì nó gắn vào trong người á. Trong cái máy đó thì nó có cái insulin ở trong đó. Rồi cái máy đó nó check cái insulin cái level blood sugar level trong người, xong rồi nó cho cái insulin vào, thì như vậy là cái điều trị nó đều hơn và nó tốt hơn. Thì ông ta hỏi rằng là bên Việt Nam có cái máy đó hay không?
Dạ bên em mình chưa có thầy ơi, tụi em chưa thấy cái này, tụi em chỉ giờ tụi em dùng cái basal bolus là chính, tại vì nó dễ cho bệnh nhân hơn. In Vietnam we don't have this machine because
no,
it's quite
right.
expensive.
Insulin
and,
pump.
Yeah,
Yeah.
we don't have pumps here, so it's quite new for me. And I don't know, I don't see any patients using pumps in here. And I haven't seen any patients.
Someday.
Yeah.
Yeah. So I agree with your plan. And do you have, when she came in, what her hemoglobin A1C was?
I don't know. So I think it's lower than 6. I don't know. I don't have it in the reports. Maybe the doctors will check it another day. But when I
Would it suppose her hemoglobin was 6, A1C was 5.7?
Oh, okay.
Would you, or 6? Would you be surprised?
No, I don't.
No,
I won't be surprised.
because the hemoglobin A1C is a measure of what the blood sugar has been for the last few months, right?
Yes.
This happened quite soon.
Yeah.
So it wasn't enough time to cause a change in the hemoglobin A1C to go up. So I'm not surprised. Yeah. So, but that's something that you will monitor as part of her treatment,
Yes.
right? Yeah.
Yeah.
As you go along.
Yeah.
Yeah. Yeah. So what else? Let me see.
Okay. So about any other one is
Oh.
normal. So this
Oh,
is
yeah, right. She had to have surgery. Yeah.
Yeah. So I have my last diagnosis at 7-day post famous surgery with mild DKA, iron deficiency anemia with a new onset type 1 diabetes with blood. Famous surgery is the propelling of this patient.
So, yeah, the anemia bothers me if it's really anemia.
I don't know. I will check.
Because the hemoglobin with the blood gas was 13.
I don't. Well, I think that the hemoglobins in the IPGs maybe they forget it to change. They forgot to change the value.
Okay.
So
Because there's only a couple of ways that you could have iron deficiency anemia.
Yeah.
One is bleeding.
Yeah.
Now, she came in with anemia. With her
Yeah.
femur, with her femur fracture, she could have bleeding into her thigh, right?
Yeah.
So it shouldn't, her iron level should not be low, but I would first think, if you have someone with a femur fracture, you're going to have bleeding around there. And that's what I would think rather than an iron deficiency anemia. The only way she could actually get iron deficiency anemia is if she was bleeding, either from excess, too much bleeding from menstrual periods, but you say they're okay,
Yeah.
or gastrointestinal bleeding. And there's no reason an 18-year-old student should have gastrointestinal bleeding, right?
Yeah.
Now, to get it from diet, you have to be profoundly, is she a vegetarian?
No, she is not vegetarian.
Yeah. It's pretty hard, I think, to get iron deficiency anemia
Oh, yeah.
without bleeding, unless I'm wrong. Let me explain my experience in Vietnam from many years ago.
Yeah.
I used to see a lot of iron deficiency anemia in children in the villages.
Yeah.
How? They had Encyclostome duodenale. They had hookworms and a lot of hookworm disease. And a single hookworm can consume, Tak, if you know the answer, I will pay off your mortgage. How much? Unless you don't have a mortgage. Anyway, any guess how much blood one hookworm can consume in one day? Between 0.2 and 0.3 ml. So they have a lot of worms. So I would see hemoglobin 4, hemoglobin 5 in 6-year-old children with a significant hookworm. All the kids had worms. I mean, I think things are much better in general now, but when I saw iron deficiency anemia a lot with worms, with hookworm, not with roundworms, not with ascaris, but with hookworm. Tak, have you ever
Yes.
seen that with, huh?
I saw ascaris, but I didn't know about hookworm.
Yeah, it's the hookworms that drink all the blood. I don't know if they drink it or if they eat it.
The
Huh?
cycle, is it because they don't wear shoes and they are barefoot, and so the hookworm will get into the body through the skin. Is that right?
Correct. Yeah.
Yes.
And I used to see Clinorchus sinensis with obstruction of the biliary tree. And the ascaris, well, we're getting away from the diabetes. So yeah. You know what, Tak? I'm writing my book now, finally.
The live story about
because
Vietnam. Yes.
Yeah, because she says, I'm Lam, and she says for the kids, I need to do that. So for the last month I started, and I'm still in my chapters in Vietnam in the 1960s.
It's
when
beautiful.
I was in the, huh?
It's beautiful because we can read history from first eyewitness. It's very
From
important.
eyewitness, right? I was there in the 60s, as you
Yes.
know, in the military, and
Yes.
and then as a doctor, and then I'm starting there, and then I'm going on for my 30 years with Dom Te Hoang No, with the East Meets West, and all the projects we've done since 1988. until now. So it's going to be the story of Vietnam for me anyway. So I'm
Thank you.
reviewing my stuff. I had diaries, notes, and I have all this stuff about hookworm, ascaris. I just saw a thing yesterday. I went to surgery with a kid, had abdominal pain and typhoid, and opened the abdomen, and here's roundworm circulating in the belly because they went through the Peyer's patches in typhoid, the lymphoid tissue, they eroded through. Anyhow, nothing to do with diabetes. So we'll come back, but anyhow.
Peter, here's a question is when sodium bicarb is indicated in the treatment, you see?
Excellent question. Very rarely. And here's why. Unless the bicarb is less than, let's say, 6.9, maybe, it can be even counterproductive. You'll correct the acidosis by giving insulin, by correcting the blood sugar, by hydrating the patient. So bicarb, we can, if you have a severe acid, the pH is 6.8. Yes, then obviously if patient's 6.8, then they're going to end up seeing Dr. Tuck Nguyen also. So if you treat with bicarb, you may get a paradoxical acidosis in the central nervous system, especially with kids. With adults, it's less so. This young woman is halfway kid, halfway adult, but the 18-year-old patient, she's an adult, basically. But with children, it's hazardous to give bicarb because you can, first of all, the bicarbonate will now break down into CO2, right, and HCl, and the CO2 crosses the blood-brain barrier, forms an acidosis then, and you can get a paradoxical acidosis in the CSF, in the central nervous system, and then cause profound depression of the brain. So you have to be very careful. The other thing with giving bicarb, it can make the potassium even lower. So when and if you give bicarbonate, you have to, if you give it, you really have to be careful with the potassium as well.
I believe that the treatment you use bicarb for the treatment of the pH, not because of the level of bicarb itself.
No, just the pH. You wait till the pH has got to be, patients with a patients with a pH of 7.1, like this patient, they're going to be alert. It's not till you get to a pH that's below pH. It's not when you get the pH below 7, then it may start to affect the mental status. You have to be very careful with in the old days, when I first got into this field, we used a lot of we used bicarb frequently. Yeah, but now very, very infrequent. Let's see.
Okay, we have 1 minute left. We let Anthony. You have 1 minute to wrap up your case, and Peter, you have 1 minute to give the take-home message to the students.
Yes. So so this is all about my test, my presentations about the post 7-day post femur surgery with the DKA. So that's all my presentation. Thank you for all for your listening.
Thank you.
Yeah.
So my wrap up. Are you there?
Yes, we are here.
Okay. Here's my wrap up, students. If you see a patient with DKA, the biggest mistake is not doing something. So you see the patient with DKA, first thing, you give fluids, you establish that they have urine output. Once you establish that they have urine output, you must give potassium, even if the potassium is 4.5. You give potassium. Monitor the potassium carefully. Just giving fluids will start to lower the blood sugar. Obviously, you're going to give insulin as well. But the other thing is, don't debate how much insulin to give, 0.1, 0.2, this and that. Give insulin. Insulin doesn't cost much. Give insulin. So number one, establish fluids. Number two, check the potassium. It's critical because hypokalemia can be a very, very serious problem. I don't know if Dr. Nguyen agrees. I think you would in this case. You have to avoid hypokalemia. Okay, excellent case. Thank you.
Yeah,
Are
thank
we,
you.
Dr. Nguyen, are we doing again next week or what is the schedule? You know?
The schedule next week, we will do the same if you have time, and we appreciate your presence and your teaching and your story about how to treat the case and about Vietnam, and we appreciate that, and we treasure all these details.
All right.
Now let me ask, we have 32 students here.
Oh,
Does
good.
anybody want to have a question for Dr. Singer? You have time now. If you want, you unmute yourself and just ask. I will ask one. I will ask one to talk. Okay. Hello, Thuan. Nguyen Thuan. You have any question for Dr. Singer? You can unmute yourself. Okay.
Yeah.
Yes.
Yes. Yeah. Okay. Yeah.
You have
Okay,
any question
Thuan.
for Dr. Thuan, Dr. Singer?
Yeah. Thank you, Mr. Singer. Yeah. Hello.
Yeah, câu hỏi không?
Hello?
Why are you laughing, Tak?
We asked question in English and he didn't answer. So you speak in Vietnamese. So
Did you understand what I said?
I believe so.
Okay. Anyway, I will see you next Friday, same time.
Okay, thank you, Dr. Singer.
Okay. Thanks. Thanks, Lop. Thank you,
Thank
Tak.
you a lot.
Thank you,
Bye.
students.
Have a nice weekend.
Thanks a lot.
Okay,
Very
you
good,
too.
Anthony.
Yes. Thanks
Very,
a lot,
very good.
Very good.
Doctor.
Congratulations.
Yes. Thanks,
Yeah, excellent.
Dr. Singer. Thanks, Dr. Tat. And thanks everyone for
Okay.
listening.
Thank
Oh,
you.
thank Dr.
Excellent.
Viễn.
Bye-bye.
Thank you.
Bye-bye.
Bye bye. Thank you.
Thank you very much.
Okay.